Good evening, everyone. Welcome to Field Trip Health, and we have a very special discussion for you tonight. It is my pleasure to introduce to you Dr. Michael Verbora. He is our medical director at Field Trip Health. He's an assistant professor of medicine at McMaster University and student health physician at Seneca College and professor of cannabis at Seneca College as well. And it's my pleasure to open up the space and welcome everybody tonight. And I invite Dr. Verbora to the stage to talk us a little bit about Field Trip Health and ketamine-assisted psychotherapy.
Thank you. Thank you so much. Really appreciate that. Thank you, everybody, for joining us. And I'm just going to kind of dive in. And what I'd like to do is share the next 30 to 40 minutes with you, kind of going over particularly ketamine-assisted psychotherapy and the offering that Field Trip Health has. And then we would love to keep time at the end to answer any questions. There's usually a lot of questions. So let me dive right in. And again, thank you so much for being with us this evening. So let's talk a little bit about ketamine for mental health. First, let's talk about Field Trip. So Field Trip Health is born out of the idea that we really need to bring healing back into medicine. And that despite the fact that we have a number of pharmaceuticals available for mental health, we still see mental health illnesses on the rise and a number of mental health issues inadequately addressed. We're fortunate to be one of the world leaders in delivering personalized ketamine-assisted psychotherapy. And it's really an artistic process that's catered to the individual. We do see a whole host of different mental health conditions, and we kind of specialize in some of the most resistant mental illnesses. So we typically see a lot of patients who've been through 2 to 5 to even 10 pharmaceuticals, sometimes invasive procedures such as electroconvulsive therapy, and a whole host of different types of therapies that have unfortunately failed. We have a number of locations in Canada, one in Europe, in Amsterdam, as well as about 9 in the US. And these are led by physicians, psychiatrists, nurse practitioners, registered psychotherapists, licensed social workers, and a number of mental health care providers. And I can assure you that the vast majority of people are extremely, extremely well trained in dealing with altered states of consciousness, which is where we tend to do most of our work with our clients. So what does a Field Trip Health clinic look like? Well, you can quickly get a glimpse here. These are our 3 Canadian sites. So we have one out in Vancouver, we have our flagship and original one in Toronto, downtown, and we have our Fredericton, New Brunswick clinic as well. So they're beautifully spaced out clinics designed to produce a specific setting, which has been shown in the literature to be very important for maximizing and optimizing clinical outcomes. So what are we going to talk about today? So we're going to talk about the current landscape of psychedelics available as mental health treatments. We're going to talk about how ketamine-assisted therapy can benefit patients with treatment-resistant mental health conditions, and particularly those who are struggling to not get benefit with traditional options such as SSRIs. We're going to show you the data external to us as well as internal. I'm going to share with you the data that we have on about 200 to 300 clients and compare that to what the literature shows with ketamine-assisted psychotherapy and ketamine as well. We're going to talk about psychotherapy and why it's such an important role to maximizing and preserving long-term outcomes. And then we're going to talk about what type of patient pursues this type of therapy and who's ideal, and then who is actually not an ideal candidate because of potential contraindications. So psychedelics, let's talk a little bit about them. So there's a whole host of psychedelics out there. On this slide, I've only illustrated 6. But there's actually thousands of psychedelics. The vast majority of them are actually pharmaceutical-based psychedelics that have been made in the lab but have never found their way into modern medicine or clinical trials. But the most common, reputable, and experienced individuals with psychedelics would have heard of these before. So we have LSD, which is a molecule that's been used for many years, has a lot of pseudo-recreational value, but it's also been studied extensively in Canada, particularly Saskatchewan, as well as out west in the 1950s and 60s. It was evidenced back then to demonstrate very positive outcomes for patients with addictions, particularly alcohol use disorders. We don't use too much of it today. It's not really commonly seen, but there are a number of studies being pursued with LSD. I think about 10% of people in the world have experienced or tried LSD at some point. The next molecule is DMT. I don't know if people have heard of this one, but this is most commonly referred to as ayahuasca, which is DMT is the main ingredient in ayahuasca, which is kind of the combination of two plants and barks, which produces this very, very potent psychedelic molecule known as the spirit molecule. Produces very, very profound psychedelic experiences. Is typically consumed in a brew, usually in Peru or somewhere in South America, typically. Usually there's very large ceremonies that are held with this, and it can be extremely, extremely potent. That's also being studied for a number of diseases and disorders today. And so it'll be interesting to see what type of issues it may resolve with based on the evidence with years to come. Psilocybin, I think most people have heard of this one. It's what we find in magic mushrooms. About 5 to 7 years ago, a landmark study came out that demonstrated a single dose of psilocybin was able to almost cure, essentially, end-of-life anxiety for patients suffering from palliative patients suffering from end-of-life anxiety. And that persisted for as long as 5 years for the patients that lived for that long. So just imagine the paradigm shift if a single dose of a medication could provide 5 years of relief versus taking 2,000 to 3,000 pills during that time that might only mask symptoms. So psilocybin is probably one of the leading candidates for ongoing research today, particularly for treatment-resistant depression and perhaps even addiction disorders. Then in the bottom left, we have MDMA, which is, kind of the rave drug, I would say. It's called ecstasy on the street. It's very heart-opening. People who consume this drug feel an abundance of warmth and love typically. But what's remarkable about this molecule, even though it's typically used in a rave setting, it's actually been demonstrated to be potentially curative for PTSD. So today we don't have very good options for post-traumatic stress disorder. The evidence isn't great for the treatments. We tend to just use the same drugs we use for anxiety and depression for PTSD. We don't have really good standardized approaches other than some therapies. And so some of the studies are demonstrating as much as 70 to 80% of people who undergo about 2 to 3 doses of MDMA no longer meet criteria for PTSD about 3 to 6 months later. This is suspected to be the first kind of approved psychedelic drug in this renaissance, and that could be perhaps at the end of 2023, so as little as 18 months. You have THC, so most people in Canada are familiar with cannabis by now. THC is a very mild psychedelic drug, and if used particularly with a ritual, with the right set and setting, perhaps, like Rastafarians do as it's part of their religious culture, it can produce, very spiritual effects for people and can alleviate a lot of pain and suffering. And then you have mescaline, which is the main ingredient in peyote, used predominantly by indigenous tribes. It's a sacred plant, unfortunately, an endangered species. And this is also, what they call the divine messenger. It produces very profound psychedelic experiences and is very ingrained in the indigenous culture. So those are all the psychedelics that we've kind of maybe heard about and learned a little bit about and how they're going to slowly make their way probably into our culture and into our medicines. But today we really only have one molecule that we can work with, and it wasn't ever designed to be a psychedelic. It's ketamine, and it was designed to be an anesthetic. And the purpose behind designing this anesthetic was to design a safer anesthetic. Most anesthetics bring you closer to death. So they slow your heart rate down, they lower your blood pressure, so you're closer to death, and that's why you need a highly trained doctor usually to watch over you while you're under surgery. But with ketamine, what's nice is it's extremely, extremely safe. It doesn't slow your heart rate, lower your blood pressure. It kind of does the opposite. So it can raise your blood pressure, increase your heart rate a little bit, but still produce anesthesia. So that makes it substantially safer than other medications, which would cause you to knock out and forget to breathe. So we use ketamine every single day in the emergency room. Children are probably one of the largest groups of people who get ketamine, and they get very, very big doses of ketamine in the emergency room before, let's say, resetting a fracture. And the doses that they give for children in the emergency room are about 5, sometimes even 10 times higher than what we would use in our clinics for a sub-anesthetic dose, which is a psychedelic dose. About 20 years ago, literature started to be published that there was strong antidepressant effects with ketamine and that they were really rapid. And so we learned from people undergoing surgery that they were feeling really positive after coming off the anesthesia. Eventually, some people started to do some studies. And over time, what we realized is that ketamine is today probably the most rapid antidepressant that we have available for patients. What's really nice about ketamine is it's generic, it's relatively cheap, but it's the services around there that allow us to deliver, an exceptional experience that produce positive outcomes. It's a fascinating molecule. So unlike typical options, antidepressants that work predominantly on serotonin or noradrenaline. Ketamine is special because it works on glutamate, which is like the master molecule of the brain. How does it work? Well, it works through what we call dissociative effects through NMDA antagonism. And it's just a fancy way of saying it gives the brain a break and it allows the brain to disconnect from ordinary thought. And then that allows a whole host of different unique thoughts to kind of come to the surface and allows different parts of our brain to communicate that typically don't talk to each other. What's beautiful about ketamine, it's extremely safe and it's extremely well tolerated. On average, less than about 5% of patients who will take a sub-anesthetic dose in our clinic will experience side effects. And the most common is usually nausea, upset stomach, but we can easily treat that and it's well tolerated. This is a very fancy slide, and the take home from this slide is really that ketamine produces a window of opportunity for the brain to enter a neuroplastic state. And so what ketamine is doing is it's modifying some brain molecules, brain-derived naturopathic factor and mTOR, and these are molecules that allow your brain to make new connections. So the saying, you can't teach an old brain new tricks. Well, if you're taking psychedelic drugs or ketamine, for example, we can teach an old brain to learn new tricks. And so this has been demonstrating with other psychedelics as well, such as psilocybin, that new connections will be made in the brain and old, let's call them stubborn or ruminating connections, which also typically cause our suffering, will be disconnected. And so this is one of the mechanisms by which ketamine works. But when you pair that with psychotherapy, there's a synergistic effect. It's that window of plasticity is heightened, and we take advantage of that catalyst, ketamine, to ingrain what we hope is long-term changes in behavior. There's a part of the brain that's really, I guess, deactivated when you take psychedelic substances, and that's what we call the default mode network. This is the network of brain region that's kind of activated when your mind's wandering or ruminating or thinking about a bunch of stuff. It includes your ego or your identity typically. It's a whole bunch of different sections of the brain that kind of light up. It's communicated with language and speech areas, and it might be responsible for that internal monologue that many of us have. And what we find with psychedelics is that it loosens this network a lot. So it's kind of, if I could use a computer as an analogy, it's kind of getting to the operating system level, and what it's doing is it's shaking up the code a little bit and allowing a broader perspective on all the pieces of the operating system that are going on. And so when you loosen that network, you start to find that you can wander in different places, and that when you have a lot of difficult rumination that creates, anxiety or depression, we can loosen those networks up so they're not so strong. The patients who have highly what we call rigid networks in their brain, or high entropy states, or low entropy states such as addiction, OCD, anxiety, depression, their neural structures are very rigid, and they're the types that benefit most from psychedelics because it loosens those rigid networks. On the contrary, patients who already have very loose networks, such as patients with psychosis or schizophrenia or manic phase of bipolar, giving psychedelics to someone with already a loose network probably isn't the best idea. Okay. So what does the data show on ketamine for depression? So this was a study done in IV ketamine. So this is just the drug itself. There was no therapy demonstrated. This is one of kind of the big studies that was launched a number of years ago, compared it to a placebo. And what they found is that just in 15 days, there was, a dramatic reduction in a validated medical questionnaire on depression. And so this essentially makes it the fastest acting, rapid acting depressant that we essentially know of. Most pharmaceutical drugs like SSRIs, they take about 6 weeks to take effect. And it's not typically as dramatic as you see here on this slide. The reductions that we see from SSRIs are actually quite minimal, just slightly better than placebo. And then after 6 weeks, sometimes we have to titrate that dose up. So we have to increase the dose and wait another 6 weeks to see. And so you can imagine waiting 12 weeks when you're really suffering or you have a lot of suicidal ideation is not really idealistic. Or if you've tried 1, 2, 3 SSRIs, trying more SSRIs at that point, hoping for something to benefit. The data shows that the probability of a 4th or 5th SSRI working approaches, 5 to 10%. And so there's, a lot of patients find themselves on their 3rd or 4th pharmaceutical drug for mental health, unfortunately. And the probability that these drugs are going to work for them at that point is less than 5%. And, doing the same thing over and over is the definition of insanity. So For a lot of these patients, something innovative like ketamine or psychedelics is really an opportunity to approach their mental health from a completely different perspective with probably a much higher probability of success. So let's talk about ketamine-assisted psychotherapy. So I just showed you the data on IV ketamine. IV ketamine is typically delivered in what we call a biomedical approach, where it's you deliver the drug, you go for a number of sessions, and there's no structured psychotherapy about that. You're kind of typically left to your own to figure out how to take the experience and integrate it into your day-to-day life. And some people might have the means to have coaching or psychotherapy to do so, but the vast majority of people are spending their income on just the ketamine treatment. They're not getting the supportive care that's usually typically required to build in those long-lasting neural connections to lead to behavioral activation and change. This is a study that was done across about 4 to 6 sites in the US. And what it looked at was ketamine-assisted psychotherapy. It was about 300 to 400 patients. And they treated a whole range of mental health conditions, common things like depression and anxiety, but also post-traumatic stress disorder, addictive and substance use disorders, obsessive compulsive disorder, eating disorders. And what they found consistently in their ketamine-assisted psychotherapy program, which is the combination of ketamine and structured psychotherapy, they found about a 50% reduction by completion of 4 to 6 sessions in anxiety and depression, which is relatively remarkable. Again, that's just 2 to 3 weeks, and we're seeing over 50% improvement for patients who are typically very resistant to mental illness. And the average person in this study was taking about 3 pharmaceuticals at the time, which is pretty high. So let's kind of shift gears. So at Field Trip, what we looked at a number of years ago before starting this company is we looked at all this data, and we had to agree upon what type of model we believed in. Did we want to go just an IV ketamine route where we didn't have the supportive care, which is a biomedical model? Or do we really want to try to bring a deeper sense of healing, connection, and community to the care that we deliver, which we call a biopsycho-social spiritual model? And thankfully, we settled on the latter, which is a core philosophy of the individuals who are part of this company. We really believe that patients are more than just their biochemicals. And there's actually, ironically, a study that came out just today demonstrating that the whole model of low serotonin for depression essentially was just debunked today. So we've been told for the last 20 to 30 years that low serotonin is predominantly responsible for people feeling depressed or anxious. And now they're finally coming out with studies that say, well, actually, that's not true. It's not a molecular issue. And I think intuitively, many of us in the field know that. We know that humans are far more than just biochemistry, that we're social beings, that we're spiritual beings, and that the psychology of our relationships and all that plays such an important role in our overall mental health. And so we're focused on a biopsychosocial spiritual. We invite all those parts of individuals, into the space when we provide the care that we do. So our program is quite robust. It's quite intense, and it requires a very big commitment for patients, but I think the vast majority are going to get far better outcomes at the end. So what we do is we start with a psychiatric consultation to make sure that patients are a good fit for this program and that it's a safe therapy to give them. Then we introduce them to their therapist that will be without them for the typically 3-week program. And they do what's called the preparatory session, and we'll talk a little bit about that. And then after a 1 to 2 preparatory sessions, they'll do a psychedelic exploratory session, which is typically a low dose ketamine. And it takes a couple doses to kind of explore to see how people respond. So there's not a one size fits all or one dose fits all. We have to start low and see how people respond. Some people are very sensitive. They do well at low doses, and other people require higher doses. And we take our time over 4 to 6 sessions to achieve and target that peak experience. After every 1 to 2 sessions, what we offer is an integration session. And this is a really, really key component of psychedelic care. And if you talk to anybody who's been working with these molecules for the last 10 to 20 years, whether it's through research or through spiritual practices across the world, what they'll tell you is that the integration of the learning is where the magic happens. It's really where we can solidify the connections and try to make them long lasting. So we provide that integration after every 1 to 2 ketamine sessions for a total of typically 3 integration sessions. And then we typically discharge patients after that 6 ketamine sessions, 3 integration, and the prep up front. And that's a typical program. And that's really just based on the literature, which shows 6 ketamine sessions to be efficacious for treatment-resistant illness, particularly depression. So what does the prep work consist of? So prep therapy is conducted typically with our registered psychotherapists, sometimes some of our social workers. Happens before dosing, and we help patients approach the ketamine experience with a very open and receptive mindset. We do a ton of goal setting, intention planning, and then we, try to quell the nerves that usually come up because a lot of people don't know what they're jumping into, and it's a lot of unknown. And so we try to build that courage up and encourage them to just sit with the experience, try not to mentally digest what you're experiencing, and just try to embody whatever's happening and taking place. And whatever may manifest, may manifest. And we try to just roll with those punches. And we try not to control the experience. We just let what happens. And for whatever reason, the brain is disconnecting from ordinary thought, and it allows other experiences to kind of come to the surface that typically have some type of meaning, so whether it's a spiritual meaning or a deep connection to something. After the preparation therapy, they go through their dosing sessions, which we'll talk about. And then we have that integration session, which it's kind of the secret sauce that really ties together the experience. This is done after usually 1 or 2 ketamine experiences, and it's about crystallizing the findings of these experiences. And then we try to devise tactics to bring lasting, meaningful change in patients' lives. And a lot of patients will sometimes say some things that are very obvious during their experience. Oh, I need to exercise more. I need to eat healthier. I need to spend more time with my family. These are kind of common things, and we all know it intuitively, cognitively. But when you really, really experience it and you feel what it's like to be connected to those things that are more important for you, you feel very, very motivated to actually enact those changes. And so what integration therapy does is it tries to capitalize on that emotion and that feeling to try to start building in those patterns of success. So what is a psychedelic experience like? I probably get asked this question the most. What is it like to have a psychedelic experience? What am I going to experience? And so the truth is no 2 experiences are going to be the same. How we deliver this medicine is either through a lozenge in the mouth that rapidly dissolves, or we use an intramuscular injection depending on the location. And that delivers a relatively rapid, quick-acting dose of ketamine, which typically lasts about 45 minutes, maybe 60 minutes. We encourage people to close their eyes and put eye shades on. What that does is suppresses downloading of data, so it allows the brain to just kind of process what's in there. It allows them to be more meditative. And then we also pair it with music. And so this music is demonstrated in the literature to be synergistic. And together the combination is typically a very amazing experience for most people. It's not uncommon for some people to have very difficult experiences, not so much with ketamine, but other psychedelics, particularly like the ayahuasca, DMT, or psilocybin. Sometimes people have very deep and hard experiences, and they go through it, but when they work through their therapist and they try to make sense of it, they get a sense of purging something that was very negative inside of them. And that's really the only way I can articulate it. And the saying in the field is, there's no such thing as bad experiences. There's only difficult experiences. And so we try to make sense of whatever kind of comes to the surface and see what meaning that brings. Patients are monitored by a nurse practitioner or a medical doctor. We check their vitals. We make sure that they're safe during this time. We've dosed thousands of patients, and knock on wood, we haven't had any adverse outcomes. Everything we do is highly individualized. So we start everybody off on typically the same dose, but depending on how they respond at the first visit, we'll escalate the dose slowly or rapidly, depending on kind of the feedback. So we really rely on patients to help guide us to their effective dose. We have a rough range for the vast majority of people, but people are unique. And sometimes we're very surprised for people who need very low doses to get to a very meaningful experience. So we offer kind of 2 kind of programs. We offer a Core 4 and a Core 6 program. It's really dependent on the individual, the severity of their mental illness, and how essentially deep they want to go. So it's either 4 or 6 sessions. It can take place as fast as 3 weeks, but typically it's about 4 to 6 weeks, or 8 weeks if it's a longer program. They get therapeutic support throughout their entire journey from expert therapists and licensed medical staff at all times. And a lot of patients, after they go through our program, will report a ton of personal growth, clarity, a massive increase in connection to whether it's nature, themselves, to their relationships, to their work. And then a lot of them will kind of work with existing therapeutic support and integrate over time. Usually a lot of people have a lot of information that comes to them. So they have a lot of material to work with for months and months. And the best way I can really describe it is it's kind of like therapy on steroids. What patients will say is, it would have taken me 5 or 10 years to get that change in therapy going every week, and I just got it in 3 or 4 sessions of ketamine. And so ketamine is just massive catalyst for therapeutic opening. Now, a really important thing about psychedelics and ketamine is it's the set and setting are so important. So when you look at a drug experience, whether it's recreational or medicinal, there's 3 components. It's the drug itself, the dose, the quality of it, but there's also the set, so the mindset that you're in, right? So the mindset of, being out in nature, going to a music festival is very different than going to a clinic with set intentions to get better. And then there's the setting. So where are you doing it? Are you doing it in a large group of people who are dancing in a very tight environment? Or are you doing it in a very safe space with people you trust, who you feel comfortable opening up with? So you could take the same dose of a drug, but have very different mindsets and very different settings and get completely different experiences. And so we've known this for many, many, many years. But it's really all of our drugs that we prescribe, we never really consider the mindset or the setting that we deliver these drugs in, especially psychoactive drugs. So we have spa-like clinics, and the goal of walking into one of our clinics is to immediately create that awe so that people immediately enter a brain space of discovery, curiosity, wonder, and change. We bring a ton of warmth and support. It's a very white glove service. Caring for these patients and our clients is the utmost importance to us as a team. And there's nothing we want more than to see very positive outcomes. We use zero gravity chairs, noise canceling headphones, special playlists, weighted blankets. It really is quite the experience. And this is the setting that we provide. So this is our Fredericton, New Brunswick clinic. So very inviting, very welcoming, very unique spaces. This is our Toronto clinic. So these don't look like your typical clinics, right? I don't think you want to be doing a drug that alters consciousness with beeping machines, buzzers, people running around, hearing carts going everywhere, overhead noises calling out emergencies. That's not a very therapeutic setting for healing. And we know this. And then this is our Vancouver, BC. So these are specially designed clinics, and this is just based on what we know to be the best, ideal environments for doing this type of work. So what is the field trip data that we see? Well, it's quite interesting because we have essentially the same outcomes that's been validated in the literature that I showed earlier. So this is a study that we conducted on 220 plus patients. We looked at the depression coming into the program. We have on average people with moderate to severe depression, and then we have moderate to severe anxiety is the average overall score for people. And then we look at during and post-program. What we see is over a 50% reduction in just about 3 to 4 weeks. And now we also have data at about 3 months, which shows a sustaining of that. So it's almost exactly 50% reduced at 3 months. So there's very good durability in our program. There are patients who come back after their first 4 to 6 sessions, maybe at the 3 or 6 month session for 1 or 2 more sessions, which we call boosters or maintenance sessions. And then, we just continue to do progress with them. But the ideal here is to really invite, a healing relationship with the individual. And it's not the idea to create a dependence on a medicine to come in every week to get. So we really try to build external resources for patients to use, so that we try to save the ketamine to catalyze very big experiences. So what do patients say who go through our program? So I'll talk about Byron here, former Canadian Armed Forces infantryman. After years of feeling stuck, I finally feel like I have all the pieces I need to improve my mental health. I'm back into fitness and more open to exploring things. I've learned a lot about intention setting and integration. I've gotten back into reading for the first time in years. Katie here says, my mind was open to the full experience of being human. I had been blocking myself off from some things because I was afraid of the emotions that were associated with them. Ketamine allowed me to explore these dead zones when I did the treatments in October, and I've even gotten better since. These treatments honestly set me up for success over time. And then Bruno, another former military and performance coach, says, I think the biggest breakthrough and most impactful thing is the integration 24 hours later with therapists while you're still in the residual effects of ketamine, which actually gets you to look at your trauma while you're dissociated from it. I still go through good days and bad days, but now I just have more tools in my toolbox to help me cope. That's a great analogy there. Ketamine is very, very safe, and the vast majority of people qualify from a medical perspective. But there are a number of contraindications. Just like every medicine, there are some patients who just can't take it because it may interact with them negatively. So pregnant women and nursing mothers, individuals with a very high BMI or sleep apnea sometimes are contraindicated. We don't currently treat substance use disorders, particularly alcohol use disorder. That doesn't mean patients can't be using substances. This just can't be the primary diagnosis right now. But what's really interesting is that there's just a study that came out a couple of weeks ago looking at the effects of ketamine for cocaine, cannabis, and tobacco and dependence. And what we're seeing is very good scores in that. And so I anticipate we'll be offering that in short order. Individuals who are psychotic or have psychosis aren't good candidates for this therapy. It loosens already a loose network, which isn't ideal. You have to be able to consent to treatment. You have to commit to the program. You need to have a safe ride home, so you need support structures around you. We also make sure patients have the support structures once they leave us. So we also offer an aftercare program with psychotherapists in our communities that can be virtual so that they can continue to do integration once they leave our clinics. Acute brain injuries is also a contraindication, and then uncontrolled health issues. So anybody with uncontrolled medical issues need to kind of address that first. The big one just mostly being hypertension, because ketamine does slightly raise blood pressure, but it's usually not an issue. So those are kind of the medical contraindications. So how can you work with us? How can we help you, your patients, your friends, your family? So in Canada, all of our clients require referrals from doctors or nurse practitioners. We typically receive those either online through a form submission or just emailed or faxed to us. And then they have an OHIP covered in Ontario, and our other provinces is also covered visit with our psychiatrist. So there's no financial commitment for patients up front. We approve or deny them at the beginning, and we let them know if they qualify or don't qualify based on criteria. And there's no charge to them that's billable by the provinces. And if they're approved, their treatment is scheduled. The cost of the program is highly variable. We charge essentially hourly for psychotherapy only. We don't charge for the delivery of the medicine, and patients can take all those receipts to their insurer and get reimbursement for the psychotherapy component to whatever their insurance covers them for. If you're interested in referring patients or sharing this with anybody, fieldtriphealth.com is where you want to go and check out. Yeah, we have a very multi-touch system that connects with patients, informs them of everything going on. They have online portals where they can journal, report their mood on a day-to-day basis, have therapists check in with them. So there's a ton of connection with us and a ton of support while they go through potentially life-changing experiences. And then, of course, we always send a discharge summary of the program to the referring physician or nurse practitioner. So that's it for my presentation. I'm happy to field some questions, and I'm going to leave my email there on the screen. It's just michael@fieldtriphealth.com. I'd love to get any questions. If we don't get to them today, feel free to blow up my inbox. There's nothing more than I love to share our experience and knowledge about this field of medicine. Thank you.
Hey, thanks, Dr. Verbora. I really appreciate your thoughts and insights on all this. We have a nice group of active participants tonight. We have a few questions lined up for you.
Let's dive in.
Okay, cool. We can probably just go in the order that we received them. The first comes from Stephen, asking to know some of the characteristics of the study population in the research that you mentioned earlier. That was the Dorian study. And if they were all met the criteria for TRD or not.
Yeah, that's a good question. So the answer is no. So TRD was just one of the diagnostic kind of inclusion criteria. It was very, very broad. So out in the US at those 6 sites, they treat anybody almost with any mental health condition with ketamine. Most people have failed 2 medications. So, we have a definition of treatment-resistant depression of failing 2 medications. It's just an arbitrary definition. We don't have a definition for treatment-resistant anxiety or treatment-resistant OCD or treatment-resistant PTSD. I think one could extrapolate and say maybe it should be 2 medicines for all of those as well. But by and large, the majority of patients on average had used 2.7 meds for their mental health, to be exact, in that study. But their primary diagnosis could have been TRD, depression, OCD, generalized anxiety disorder, post-traumatic stress disorder, or substance use disorder. So there's about 6 or 7 different disorders. Depressive disorders and anxiety disorders made up about 50% of the group, and then the other 50% was divided between those other diagnostics. Great question.
Thanks, Dr. Verbora. Next one comes from Mary. She's asking if we can share any research or data on the neuroscience behind rigid versus loose brain networks and ketamine's impact on them. And also if we can share any research coming out around MDMA for PTSD and psilocybin on end-of-life anxiety.
So the answer is yes. So I would say email me with specific research or journals that you're interested in. I could forward you kind of a list. The scaffolding brain networks, the study that comes to mind is a David Nutt study out of the UK. It was on psilocybin, and it shows the brain on placebo, the scaffolds and how they connect, and then versus the brain on psilocybin and how, you know, the brain just essentially completely lights up and different areas of the brain start talking for the first time. So I can definitely share that one. And ketamine is very similar to that. All psychedelics are probably very similar to that. And sorry, what was the second part of that question?
For sure. The second part was
end-of-life anxiety.
Yeah, and it was psilocybin, which you started to touch on.
Yeah. So that was kind of the first study that really motivated me to pursue this field because I want to say it was NYU or it could have been Johns Hopkins. It's one or the other or both. And they did a single dose of psilocybin for end-of-life anxiety. Like literally, if you Google end-of-life anxiety, psilocybin is probably the top 2-3 hits. And when I read that study, the effect size was just so massive. And I was working in my cannabis clinic at the time. And mind you, I'm a bit of an open mind practitioner, and patients have really helped lead the way for that. I read the effect size and I thought to myself, you know, I thought of all the patients that kind of come in and out of my office like a revolving door, and how many times I've just switched their SSRIs, and we both felt frustrated because they knew and I knew it wasn't going to work at the 4th or 5th one, and thought to myself, wow, this could be potentially game changing. So it was a single dose of psilocybin was demonstrated to reduce end-of-life anxiety. And that persisted for many, many, many months. And for the people who lived longer than the 1 year expected, that single dose is still listed on average the top 2 to 3 experiences of that individual's life. And we don't really have any treatments for end of life. This is a huge gap, I would say, in Western healthcare. You get a palliative diagnostic, you get diagnosed with a in-term palliative from a disease. We don't really provide great resources and services for dealing with end of life. And how to face that. And so, one, we need to build out that network. And 2, I think these therapies, it's nice to know that there are therapies that can potentially help with that.
That's great, Dr. Verbora. It's not a question here, but I don't know if you want to touch on the special access program and how we work on that a little bit.
Yeah, it's exactly what came to mind. So we do have a special access program, and it's not our program, but it's the government of Health Canada's program. And what it is there is an application that a physician typically can make for a patient to request a drug that's not either legal or have a drug identification number. And so I can, for example, apply for patients to access psilocybin or MDMA. If they're deemed essentially to be palliative. I've gone through a couple. It hasn't been a great experience because I don't know who's on the other end of reading these applications. There's been a number of patients approved to date. We've treated a couple patients with psilocybin, but the criteria is very, very strict. So to access legal psilocybin or MDMA, which nobody's been approved for MDMA to date in Canada, legally outside of a research trial, it's very, very difficult. The criteria is very, very narrow, but it's still there. And so I have about 4 applications that I'll be putting in the next week or 2. So, at our next webinar come, and hopefully I can have a couple slides on that. We have treated a couple patients in our clinic with post-traumatic stress disorder with psilocybin, and they have very similar outcomes to ketamine. The big issue with special access, and particularly psilocybin and MDMA, is it might not be the best medicine. Ketamine might be better for a majority of people because you can't take those drugs if you're already on SSRIs. So a lot of people want to do psilocybin, and there's this perception that it might be better, but you can't safely take it with an SSRI because of a risk of serotonin syndrome. Whereas with ketamine, you can safely take it with an SSRI. So ketamine is probably actually going to be the first drug that most people take. And as they go on, perhaps a journey of connection and finding relief and healing. Eventually, if they're off medications, they'd be able to access psilocybin and MDMA in the future.
Nice, nice. We have a question from Lucretia. She does mention that even though doses may not be a one-size-fits-all, what type of doses are being used in clinic are you seeing?
Yeah, so in the Toronto clinic, we use mostly rapid dissolving lozenges. We start at about 200 milligrams typically on our first visit, give or take. Some patients will come in and say, oh, I'm really, really sensitive, start low. And some patients say, oh, I had to go in surgery and the anesthetist said I needed twice as much as anybody else. And so we take those stories and we believe patients and we say, okay, we'll customize your treatment. And so we might up somebody on the first visit if that's their story, or we might lower them if it's the contrary. And then we go up every visit by 50, 100, maybe 150 milligrams, and then we see how it evolves. Now there's value at even low doses that aren't psychedelic. We call it psycholytic dosing. So psycholytic dosing allows it's a little bit more conversational. It's more of a lubricant and allows a little bit of disconnecting, but also feel a lot more warmth around some of our ordinary thoughts and not taking it so serious typically. Whereas a psychedelic dose is complete disconnection, right? It's blasting off and completely leaving your body essentially. And I find in our experience, and like all things in medicine, it's better to kind of ease patients into that experience, build confidence, build trust, so that they aren't confronted with a lot of fear when they do face that experience.
Great. We have a question from Stephen, who's just asking for clarification on what we mean when we say registered psychotherapist. Are we talking about psychiatrists, clinical counselors, psychologists, or any of the above?
Yeah, so predominantly we're talking about psychologists, but we have, I think, psychoanalytics individually trained. We have social workers. We have in some of our clinics like art therapists, and probably a couple other of therapies, but by and large, it's psychologists that we use for delivering the psychotherapy. We do have psychiatrists who do the first initial visit to approve the medicine and prescribe the medicine.
We have a question from Samuel asking about data with ketamine and substance use disorders, and if not that, then depression and anxiety amongst those with substance use disorders.
So yeah, I kind of mentioned it at the end, and maybe you can email me and I can circulate that new paper that I came across just a couple of days ago on, I think it was cocaine use disorder and maybe cannabis and maybe tobacco. It's still kind of early data, but what psychedelics are, I'll take it just a kind of side road here for a second. Psychedelics are to the brain what the telescope is to the night sky. So we are learning so much about the human brain by people experiencing psychedelics. And what we may come to learn at the end of the next decade in research with psychedelics is that all of our mental health diseases aren't different diseases and that they all have the same kind of origin. And that doesn't fit nicely in the box of Western medicine that we've created. So whether you have a substance use disorder, depressive disorder, traumatic disorder, the brain is essentially stuck. It's not firing the right chemicals, or it's got too many neurons in a spot that's causing hypervigilance. And so the etiology of a lot of these are probably the same. And we just categorize people into boxes because we literally check off boxes and say, okay, you have this one. But by and large, if you're going through a healing journey, it doesn't matter what your diagnosis is. Like, you should feel much better and the suffering should ease. So I'm kind of a proponent for recognizing a much more holistic approach to mental health and recognizing that, you don't have depression or anxiety or substance use. Like, those are just labels to make it easier for us to do our job. It's just mental suffering, the human experience being difficult.
There's a question from Shasista asking about acute or active thoughts about suicide and if that's a contraindication.
Yeah, great question. So it's not a absolute contraindication. There is good evidence that ketamine can help with acute suicidality. I have colleagues who work in emergency rooms who will deliver a dose of IV ketamine in the emergency room. Not the best setting, but it works so rapidly that it's actually probably the best drug to give in that setting. If patients have suicidality and they have the right support structures and a safety plan, and we can work with them and manage that, then we would welcome them. If the suicidality is very extreme, though, they have, a very concrete plan on ending their life. They might need a little bit more support and stability before starting this program. And we want to just make sure that we're matching the resources that we have with the needs of our patients. And so we'd love to be able to serve everybody, but we have to be cognizant of our limitations. So yes, some people with suicidality will be included, but people who have, very extreme suicidality, our program is just not fast enough for them. They need something more rapid and more inpatient, probably.
Great. Thanks for that clarification and distinction.
Yeah, it's tough.
Yeah. Just a request from Mary, would you probably follow up on your idea of like just emailing, asking for some upcoming data on CAP against cocaine use, cannabis, and tobacco.
Yeah.
She can just reach out and get in touch with you for that.
Please.
Another question that was actually kind of talked a little earlier about too is like, how does like, what's covered? Like how does insurance kind of come into any of this treatment?
Sorry, say that again.
Oh, sorry. What's covered like by insurance? Like, is this all out of pocket? Like, how can someone like, maybe use an existing plan?
Yeah. So every insurance plan is different. So you have limitations on how much you can bill, but it's so highly variable that I can't comment on any specific plan. But you would submit those bills and you would get a certain percentage back, but that could be 50%, it could be 100%. It's just so highly variable. So I can't I can't really, give a better answer than you'd have to kind of look up your insurance. You'd have to show them what a bill would look like, and they would tell you what would be covered.
Mm-hmm. Okay, I'm going to move into a comment from Barbara. I'm just going to read it out as it goes. I'm a palliative care doctor, and I take some offense to your comment that there is no treatment for palliative care. That feels like, what about deep, unconditional, positive regard and empathy, etc.? I'm absolutely supportive and am training in psychedelics to assist. It is still important to add that it can add to good palliative care, but it is not a replacement for a good team of practitioners to support the many symptoms and issues that face people at the end of their lives.
Yeah, thank you, Barbara, for that comment. And I apologize if it came across that way. How I was trying to phrase it was, I don't think we do a great job typically in Western medicine of addressing spiritual issues around end of life. I think palliative care doctors are predominantly the ones that are burdened with that. I think, unfortunately, we're very slow to send patients to palliative care doctors. I think the stigma is decreasing with palliative care doctors, but I still also hear from patients that they have this perception that once they're sent to palliative care that, oh, that's the end of my life. Like that's a bad thing. Whereas I have a very different approach. Like I like to involve palliative care very, very early, because to me, palliative care is palliating. It's palliating pain. It's palliating suffering. It's palliating sleep. So I just think that how we typically approach it is we're just so slow to engage it. And a lot of the physicians who are dealing with terminal illnesses, let's say oncologists, they typically don't necessarily have the training to have the spiritual conversations. Of course, that's not for everybody, but I think so many of us are siloed and focused on the medicine and outcomes and evidence-based medicine, that to try to also have the spiritual conversation simultaneously as the oncology conversation or the radiation conversation, I just think, unfortunately, they're siloed. And I just think a lot of us actually need way more training in having those spiritual conversations. And it's great that you have that training and that expertise. And there's nothing more that I would love to have a way better reduction in stigma around palliative care, and more individuals like yourself offering care to patients with terminal diagnoses far earlier to support them. And so there's a huge stigma there that we have to break. And I think palliative care is going to be a huge frontier for psychedelics. And I think palliative care doctors are the ones that need to lead it, because they have the most experience with dealing with end of life. And I think that needs to be integrated a lot better with Western medicine. Like, how do you cope with the diagnosis? Even if you're not going to die in 5 years, how do you even cope with that diagnosis? That's something a palliative care doctor can help with, but we just wait so long to invite them in. And I just don't think that's the right approach. So I thank you for calling me out on that. I appreciate it. And I hope that clarifies, and I'm happy to continue that conversation offline or address any other comments you have. And hopefully that clarifies it a bit.
Thank you very much, Dr. Verbora, and thank you, Barbara, for your comment and the work that you do in coming into this space with us tonight. And in fact, I'll just also read that Stephen wanted to emphasize this support for Barbara and say, that's true, Barbara. My wife's brother-in-law died late last night in a hospice setting. She said the hospice offered far more peace and comfort than was ever possible in the hospital. Yes, there was help for him. So thank you for sharing that, Stephen, as well, and sending our love and condolences.
Thank you.
I have just a few more questions for you. Can you talk to me a little bit about like what's training like in the space for people who want to work closer with psychedelics in the counseling setting? How are they kind of trained, and who's able to prescribe psychedelics like this?
Yeah, so there's no formal certification or training. It's a bit scattered all over the place, from very exhaustive programs like CIAS, which is a 1-year program out of California. And then there is companies that do weekend retreats, such as Fluence, and MAPS, which is a big organization funding a lot of this research through donors, offers MDMA training. And so they're a little bit scattered all over the place, and there's no checklist to say I'm trained or not trained. Eventually people feel comfortable enough to do the psychotherapy or to hold the space for these complex assessments and visits. Technically, any physician can prescribe ketamine, technically, but most people will have some type of training. There's Integrative Psychiatry Institute that offers, I believe it's a 6 or 12-week course that also trains people on how to use ketamine, how to dose it, indications, contraindications, monitoring. We offer, obviously, training internally to all our doctors and therapists who join us, which is based on kind of all those programs. And there's not... there's no formal program for it yet, but the other thing that we should address is that when these substances do become FDA approved or Health Canada approved, such as MDMA for PTSD, it's not just the drug. This time is different. So the drug will only be able to be used by trained therapists who've completed or doctors who've completed the program training, and it'll have to be done in specific facilities that look and feel like the studies. So it's not going to be just anybody being able to prescribe the medicines and use them at home. This is a paradigm shift in how we're going to do medicine. You're prescribing not just the drug, but the protocol and the therapy. And that's very different. That's not something we're used to.
That's a great distinction. Thank you so much, Dr. Verbora. I know there's a lot of questions out there of like what access to psychedelics will look like, comparisons to the cannabis market in some ways, and that's not going to happen.
Yeah, I know that there's political pressure in a number of states. I know that there's medical programs launching in Oregon, for example. I know there's retreat centers out in Costa Rica. And obviously you can, get on a plane and fly to Peru and find somebody to give you ayahuasca. And so will those disappear? Probably not. Will they grow? Probably. I'm sure that they can do very good work in those settings. But as a medically trained practitioner, the set of values that I have is a controlled medicine with a controlled dose that's regulated in a structured framework with informed consent, with monitoring, supervision, and paying very close attention. And that structure is so important. That container is really necessary to minimizing risks and maximizing outcomes.
And that essentially guards against, that idea of like what a bad trip is, that container that you create.
Yeah. It's the saying in the literature is there's no such thing as a bad trip, only difficult trips. A lot of people find ketamine to be, relatively mild and warm, and we don't typically see a lot of bad trips. But when they do have, again, it's not bad trips, just difficult experiences. When they do come to the surface, we just work with it. We work with the material, and we try to cognitively, mentally, emotionally, physically digest it and metabolize it. And if that comes to fruition, people breathe easier, they smile easier, they feel lighter, they sleep better. And it really transforms many aspects of their day-to-day life for a positive.
Mm-hmm. So we've got just a few minutes left. I'd encourage if anybody in the chat has a few extra questions that they'd like to ask, please enter into the chat now. We'll get to it. I do have one last question for you, Dr. Verbora. What do you think the impact of psychedelics may have on the mental health care space over the next 5 or 10 years? What's going to happen here?
Yeah, it's hard to predict. I had the pleasure of hanging out with 25 residents this afternoon talking about psychedelic psychiatry residents. And I was picking their brain and asking them, well, you're the future of medicine. What do you think psychedelics are going to be? And everyone just hummed and hawed. That's the truth. Everyone just said, oh, I don't know. We're going to see. So I think there's a lot of cautious optimism. And we have to be careful. Like, when the media sets up the expectation that these are 100% cures, that really leads to failing people, because then people come in with this massive expectation of, oh, I'm going to be cured. And then if they're only 50% better or 60% better, that's viewed as a failure. Whereas, if they were comparing it to something else and they were 50 or 60% better, they'd be so much more positive outcome, right? So how is it going to evolve? I think it'll slowly evolve through multiple paths. I think they're going to be a medical channel. I think the drugs will have to be covered by insurance companies. And because they're going to be very expensive to do. MDMA therapy is going to be, in the 20s of thousands of dollars to deliver this type of care. I suspect there'll be very strict criteria medically in specialized centers with specialized trained staff. And then I think there's still going to be, recreational or decriminalized places. So Vancouver, the whole province of Vancouver, I believe, just got a Section 56 exemption. So what does that even mean? So if I'm in Vancouver and I have mushrooms on me, like, I don't think I can, it's like, I can't be really, like, it's kind of decriminalized essentially. Like, so what does that even mean? How is that going to manifest? Are people going to open up a bunch of dispensaries like they did with cannabis now that province is Section 56 exempt from drugs? So I don't know how that's going to manifest, but I suspect simultaneously, as the medical channel evolves through research and evidence, you're going to have decriminalized places, you're going to have legalized places, you're going to have black market or unregulated markets, and we'll have to see how that evolves. But it's going to be, I think, multiple pronged. It's going to be interesting.
Mm-hmm. I appreciate you sharing that perspective. Good to know that there's still some question marks around it, and it's up to us to kind of carve that out in the way that it needs to go. And Samuel actually has a question that maybe is on the heels of that, is to say, do we treat patients who don't qualify with a mental health diagnosis? Do you see this as a possible future where those without diagnosis face significant life challenges would benefit from getting treatment this way?
It's a great question. Thank you for it, Samuel. We're kind of trapped in that medical box ourselves, right? We're all practitioners and we have certain standards to meet. We know, because we talk to our patients, that personal growth is the #1 reported benefit of psychedelics. And I'm of the philosophy and belief that you don't have to be sick to want to feel well. And that's my personal belief system. But I too am trapped in the healthcare system where we rely on diagnoses to kind of move forward, and evidence-based treatments and protocols. And so I hope with time that it'll loosen up so that people wanting to come in a safe environment and just have personal growth in different areas of their life, as long as it's safe, that they'll have a safe place to do so. And I would support that. But how that's going to manifest in the medical container will be interesting. And it would be an interesting curiosity if someone in Vancouver with mushrooms, where it's a Section 56 exemption, what happens if they walked into a field trip clinic over there today? Technically, we could probably treat them for any condition because it's Section 56 exempt. So we haven't done that yet, but it's something to think about. And that's where those other elements of how this is coming to fruition might kind of rapidly progress how people use this.
Interesting. Thanks for sharing that perspective. I do love what you just said about not having to have to be sick to want to feel well. I love that. I wrote it down. I'll be taking that with me.
Okay, thank you.
So as we conclude, if you just wouldn't mind reminding our group, if they want to work with Field Trip, or perhaps send one of their patients to us, what do they have to do?
Yeah, so we just have a referral form online, fieldtriphealth.com. There's also a ton of ways to connect to us through email. We have a ton of care coordinators I can call and explain the program, tell patients or clients who's appropriate fit, who might not be an appropriate fit, kind of guide them through the process. There's a number of steps. It can be a little bit lengthy for people. And then you can, if you have the ability to refer as a nurse practitioner or a doctor in one of our provinces that we're in, we'd love to be able to serve your patients. And we'd love to get you involved as much as possible in helping patients find, healing in Western medicine.
Thank you so much, Dr. Verbora. Samuel says, thank you so much. Great presentation. Lots of gratitude from all of our participants and attendees tonight. Thank you so much. Feel free to reach out anytime. And thank you, Dr. Verbora, for bringing this space to the group tonight.
Thank you.